So thank you very much. I'm gonna share a quick story of how I got into the wonderful world of digital health that I'm in now. So very early on in my career, I spent the first few years working in very remote settings, mostly in East Africa. Um, and one of the countries that I worked in, which is probably the hardest setting I've ever worked in, but probably the most rewarding setting I've ever worked in, was in southern Sudan during the Civil War. And while I was there, the only form of communication, so I'm going to date myself. This was in 1999, and the only form of communication that we had were two-way radios. And so in order to, mobilize transportation, and this is what the roads look like, you had to drive through rivers and on sort of unpaved roads through very difficult terrain. And so I had a situation where there was a pregnant woman, very young, 16 years old, pregnant with twins, in a very difficult delivery situation, and had a knock on the door of my mud hut with my thatched roof at 2 a.m. To mobilize emergency transportation, which was this truck, to get this young woman to the only hospital in the area that had an OBGYN. And we weren't even sure if he would even be there. And so we used a two-way radio to track him down, to make sure that he was there by the time we got there. And for us, it was a 7-hour drive in very challenging terrain. And we were able to get, this woman to the hospital and to have a safe delivery, where she and the twins were delivered safely. Unfortunately, I wish that were the end of the story, but unfortunately, we found out a few days later that they all died due to poor infection control in the facility. And so what this sort of taught me as part of that experience was, one, the importance of communication within public health programs, and two, the importance of transportation. It also taught me that your communication and your transportation are only as good as the systems and the services that you are connecting them to. And there were a lot of gender-related aspects to this scenario, which I'll sort of unpack in my presentation. So fast forward a couple of years, and I had a mentor who encouraged me to pursue a PhD. And I think she, you know, had not pursued her PhD, and she really wanted me to do it. And I never really thought about doing a PhD, but at the time, I was working for a .com in New York, using technology for physical therapy and for rehabilitation. And so I started brainstorming and thinking to myself, okay, well, if I do a PhD, I really want to study technology and health. And at the time, there were a lot of people looking at the internet, but hardly anybody was really looking at mobile phones. And mobile phones were just starting to take off. I don't know how many of you remember your first, mobile phone, or how old were you were, and what year it was when you got your first mobile phone. For me, I got my first mobile phone in in 2001, because I decided that I was going to do a PhD on mobile phones and I should get a mobile phone, so I knew what I was talking about and what I was researching. And so I went to Egypt, which is where I'm from originally, and so I studied how mobile phones at the time were starting to be used to access health services and health information. And it was at a time when the mobile phone penetration in most countries was, 2 to 5% of the population. So before the full spread of mobile technology. And even at that time, I did a media analysis, and as part of my media analysis, there was a lot happening in the media around mobile phones and how mobile phones were starting to shape society. So fast forward, how many years? 25 years. And so I currently work with an organization that I helped start called HealthEnabled. And a lot of the work that we do is really focused on leveraging technology for the benefit of people's health and well-being, with a very strong equity focus and a very strong focus on, uh, in particular, women and youth, because these two groups are probably the most significantly impacted. Their health is the most significantly impacted, um, both in positive ways as well as in negative ways. And we'll talk a little bit about that. And the work that we do, really looks at understanding the ecosystem and the various levers within the technology ecosystem, the health ecosystem. We do a lot of work with participatory design, um, and a lot of this work is really moving towards effective strategy and policy, um, evidence, advocacy, and collective action. And our focus is really equity by design. And so we've taken on a number of areas, with thought leadership work that we do, including areas like prevention and response to sexual and gender-based violence, the digital determinants of health, child protection. We also do a lot of work around the development of national strategies and policies. So we've worked on the national strategies of Nigeria, of Iraq, um, as well as with large organizations and their digital health strategies like Gavi, the Vaccine Alliance, and others. And then we do have a focus on building global public goods, so resources that can be used to support the harnessing of technology for improved health and well-being, including the Global Digital Health Monitor. Um, and then relevant to this group, we do a lot of research. We have been very actively involved with the World Health Organization on the digital health guidelines, where it was, identified that there was a really big gap in terms of evidence related to the impact that digital health is having on health outcomes. And so, over the last, 10 years, we've been doing a lot of large scale effectiveness studies to evaluate the impact of digital health on health outcomes. So the digital determinants of health, and so this is, a really important area it's been around since the beginning of, the use of technology in society, but nobody was really sort of giving it a name and really trying to define it. And so, it is increasingly becoming an important part of the conversation around the social determinants of health, that there are incredible benefits to society from being connected um, to technology and to each other. And there's also some risks of being connected, and there's also risks and harms from being disconnected. And so it's really important to kind of look at the different dimensions of health and the different ways in which technology, through various pathways, can help improve health and well-being. And so, this is sort of, helping to highlight some of the aspects of, the social determinants of health and how the digital determinants of health relate to this. So think about areas maybe in your own country that may be disconnected, where there might not be really good connectivity, and the types of things that those individuals may or may not have access to. One of the biggest digital divides that exists globally is the gender digital divide, where women are 25% less likely to own a mobile phone or have access to technology. And so this is, which I'll get more into around this sort of gender intentional approach to digital health. What we're finding is that a lot of digital health interventions are being designed to help promote various aspects of maternal and child health. But if women don't necessarily have access to technology to avail themselves of those services, then they're increasingly at risk of being left out and left behind. So what we're seeing in the digital health sort of ecosystem is that there are gender dynamics and barriers that affect health and access to health and uptake of health services. There are also gender-related barriers that can restrict access and use of data, technology, and digital tools. And what we're seeing is a widening of the gender digital divide, and particularly within the health space, this risk of increasing health inequities. And so I don't know how many people in this group, you're a statistics group. I don't know if you've read the book Invisible Women, um, which is a fantastic book. Which really highlights, some of these issues of, we all live in a world that has been designed around a prototypical white male, um, which we are not, for the most part. And so, as a result, what we're finding is that, women, and other populations are underrepresented in data. So in the health sector, a lot of clinical trials are conducted not on representative samples, either by race and or by gender, which, increasingly exposes particularly women that make up half the population to different types of health risks. So in the US, we have much higher risk of delayed diagnosis of cardiac and heart conditions and cardiovascular diseases, because most of the prevention protocols have been developed based on um, you know studies of men. Um, and so, it's really important that we start becoming more active in in making sure that, research samples are representative. We also see that, women and other underrepresented populations have lower access to technology, that they're not very well represented in technology fields, and that very underrepresented in leadership and policy development. One of the initiatives that HealthEnabled has had the privilege of leading has been the Global Digital Health Monitor. And we're in the process of transitioning the monitor into the World Health Organization. In our last iteration of the Global Digital Health Monitor, we included an indicator on gender and on, whether or not gender considerations are accounted for in digital health strategies and digital health policies. And what we found is that it's, inadequately accounted for, that women are underrepresented in all levels of digital health leadership. We also know through some of the research that I've been doing with the Digital Health Exemplar study is that women's mobile phone ownership, just women's mobile phone ownership alone, is associated with greater digital transformation overall and health in particular. That primary healthcare outcomes are associated with women's mobile phone ownership, which I think is really like interesting and important to think about. We do also know that there are new health risks that are emerging as a result of technology, and we do have to approach technology, and digital health with eyes wide open. That there is an increase in misinformation and disinformation, that there are child safety concerns, and that we are seeing an increase in technology facilitated violence against women. And so a lot of these things are disproportionately, impacting women and their health. As part of the work that we've been doing with Gavi, the Vaccine Alliance, we've been doing a lot of landscaping to really understand what are the particulars around gender and digital health. And so from a health systems perspective, what we're seeing is that, a lot of digital technologies are meant to be used by health workers. But what we're finding is that, and for the most part, the frontline health workers are largely women. Supervisors are often men, and administrators and policymakers are often men. And so what we're finding is that there are gender dynamics in the health workforce, that there are digital literacy challenges. When I was doing a mobile learning initiative in Ghana, anytime you try to train the nurses in the use of different digital tools, they would hand the device to the nearest young male that they could find. And so, they were not, confident, were not interested in engaging with technology. And yet we have these sort of, desires to put these tools in women's hands without necessarily working through the design process that is needed to really make it meaningful. We also know that, for a lot of communities and environments, that the majority of caregivers are also female. And again, a lot of times women will prefer things like voice messaging over SMS or other forms of engagement. And yet, when we design these programs, the programs are often designed and implemented by young men who do not take into account, the needs of, the women that they're trying to engage with. And even within households, there are kind of gender dynamics that are happening. Early on in my career, I did a lot of work on mobile messaging for maternal, newborn, and child health. And, a lot of the work um, really quickly transitioned from using SMS messaging to voice messages to voice of an elderly woman, because that is what, um, women wanted to hear. And then we also had to develop messages for, mothers-in-law and husbands. Because they're often the gatekeepers in a lot of societies for access to different types of health services in countries like India and Bangladesh and Nigeria. We also know that there are, gender dynamics in data. That a lot of data is, often collected by men, used by men, not very actively used by women, not very actively analyzed by women. So I'm very excited about your statistical society, and and that you have this group of women data scientists. And we also still struggle with having data that is disaggregated by sex, like the simplest thing, um, and the controversies that are there. And so, increasingly, we do need to be paying attention to these things because different health conditions just manifest themselves differently in different uh, in different people. So I wanted to share two examples from some of the research that we've done. So we started, I want to say like 8 or 9 years ago, doing more gender intentional research, where we, engage male and female co-PIs in the design of the studies. We have equal numbers of male and female respondents. We really do try to make sure that we're taking this approach. And what we found is that in um, digital health interventions, where you take a gender intentional approach to the intervention itself, you can see an improvement in health outcomes in a very different way. When you don't, you see some improvement in health outcomes, but you don't see the full improvement in health outcomes and the reach that you might have if you had taken a gender intentional approach. So one study we did in Pakistan, they did not take a gender intentional approach. And one of the biggest findings from the study was that the intention was to register children into an immunization alerts and reminder system. And you had male vaccinators asking female caregivers for their phone numbers to register them into the system. And in this culture, it's like no woman is going to give her phone number to like a strange man. Um, you know, like even for the care of their child. So, that was a very, it was one of the big recommendations was that they needed to have more female vaccinators, that they needed to do a better job in socializing the program. Um, in another study where they had taken a gender intentional approach to the study, they proactively recruited more female vaccinators, and they engaged with the Ministry of Gender as part of the design of the program. They applied, gender analysis to the design of the program and to the implementation of the program. And we're now doing a phase 2 of this research study to see how the results in these like intentional sites fared as a result of that approach. So we've known that there's gender related aspects and issues throughout. Even in my PhD research, I had a whole section, and I reread it this morning, on gender and technology and and health in Egypt, from 2002. And then, when I was executive director of the mHealth Alliance, we developed a gender women's empowerment framework. And it was really interesting because as part of this framework, one of the areas that we proactively included was gender-based violence and the power dynamics there, because we do see safety and power struggles as an important aspect of technology and health. And this framework looked at, whether or not women were engaged in the development of technology and content. Were they engaged in policymaking? Were they the providers of health services and the clients of health services? And so it was not just within each of these groups, but then between these groups, like what is happening? And this was, 12 years ago. We're still kind of continuing to grapple with some of these challenges and issues. And so we've done, since then, we've done some work to look at, the use of technology for the prevention response to sexual and gender-based violence. And this is, in many ways, a much more prevalent area than I think anybody is fully appreciative of, where at least 1 in 3 women have experienced some form of physical and or sexual violence in their lifetime. And then we're also seeing this sort of rise. During the pandemic, we also saw a shadow pandemic in this area. And then we also have seen technology facilitated violence against women on the rise as well. And so we've come to this conclusion that we need to take more of a gender transformative approach to digital health, that it's not enough to take into account like gender or flag gender as a consideration, that we actually need to take on the social change that goes along with gender in digital health, so that we can have greater health equity. And so this framework has evolved and grown and become much more systematic. And we're just in the process of wrapping up a gender study where we've used the framework in Ethiopia. And what we find is that Ethiopia has very strong gender leadership. And they've insisted on having, 50-50 women in leadership positions and roles. They have very strong gender policies, including a gender digital health policy and strategy. And so at the highest level, they've been very active in really trying to mainstream gender. It has not translated into changes at the subnational level and or at the community level. And so more work is needed to really look at the societal issues that are impacting engagement of women much more actively in things like technology design, in things like supervisory roles or policy making roles, so that they can go through the gender transformation process. I'm going to start to wind down my talk and talk a little bit about health equity and how, gender does need to be accounted for as part of health equity, where health equity is, everyone having a fair and just opportunity to attain their full potential for health and well-being. And so when you have mismatches in technology access and technology engagement in data, this is just sort of like ingredients for, either sustaining or increasing um, inequity. In addition, there's also data equity. We need to be really thinking about some of these principles when we're getting more and more into the data sciences, and thinking about who is represented in the data that we are using, who is not represented. And increasingly, when you look at algorithmic bias with AI, it is disheartening how biased against women it is. And so we need more women to become more sensitive and active and make sure that data is more representative. In addition, we also need to make sure that the algorithms are more equitable. And so there are increasing frameworks to look at health equity in algorithms, and examples of harm that is caused because of the lack of testing of different LLMs from a fairness perspective, from an equity perspective. Um, and in the health sector, it does pose like physical harm and danger to people if they're not necessarily being evaluated, not just for accuracy, but for equity. And so, just some final thoughts around, making sure that we do have diverse and representative data sets, that we're auditing and we're reviewing biases, and we are communicating those biases. In health research, when you apply to do health research, you have to, go through a, internal review board that where you have to declare what biases you think there might be. But we have lost a lot of that accountability on the back end. And so when you look at most published research studies, they're not reporting on the biases and or where the samples may have been mismatched, et cetera. And so we need more of this to happen as part of the accountability and the work that we do, as well as more robust fairness measures and ethical considerations for the collection and use of data. And so some concrete like recommended actions are things like, gender analyses, planning, and monitoring. Gender doesn't happen, taking a gender transformative approach does not happen unless you know where you are and where you want to get to, and you actually proactively work your way through those processes. And so, I think some of these other areas are things that I have mentioned through my talk. And at the end, it's really just the measurement and the research as well, that that if we're measuring these things on, then we will be much more intentional about making sure that they're in place as we go along. So just want to thank you and pass um, and pass back to Cynthia.